Good morning, everyone. Am I audible?
Good morning, sir. You're audible, sir.
Yeah. So there are how many? Should we start now? I cannot see how many people have joined already.
Around 17 have joined, sir,
Oh, so but from our own department, have most joined.
as well as Dalpati, sir, and uh, from KGMU, Dr.
Okay.
Shreyams. And
Okay. Uh, can I request everyone, whosoever is able to listen to me right now, that please keep your mics muted. Uh, and if you have a question, because there is likely to be maybe 20, 30 people joining, it would be better that we get the questions in the chat box, and at some stage we will take the questions either during or at the end of the whole presentation. uh, but please do keep your microphones muted. So it's 8:03, and I'll wait for 2 more minutes until 8:05. Then we can start. Meanwhile, whosoever has joined already, welcome. It's
Good morning, sir. Dalapati here, sir.
Yeah. Good morning, Dalpati. Thanks for joining.
Yes, sir. Thank
Uh,
you.
it's
Yes,
good to see so many people join.
yes,
Um,
sir.
so it's a terrible time for all of us, not being able to see each other face to face, but that
Yes,
also compels us to do all these academic sessions over the Zoom platform or other video conferencing platforms,
yes,
which makes it rather easy or not so difficult to share these academic sessions with others.
yes, sir.
So this is a blessing in disguise and good to connect with so many of friends.
Yes, sir.
Uh,
It will be a great learning experience for our residents also, sir.
I hope so. And endocrine surgery, endocrine and breast surgery is a rather small fraternity, and we can all learn from each other. So just last evening, I was told that all the five MCH programs in endocrine surgery or endocrine breast and general surgery are going to be represented today on this uh, during this lecture. I hope we can continue this spirit of academic sharing and collaborative learning.
Yes, sir.
And
Definitely, sir.
okay, it's 8:05. Let's start. So the topic for the day is parathyroid carcinoma. And what I intend to do is talk a little bit about, because we have about 45 minutes for presentation and some time for discussion, I will have to restrict uh, to a broad overview of parathyroid carcinoma. I would try to cover some bit of all aspects of parathyroid carcinoma, its etiopathogenesis, the presentation, diagnosis, surgical and non-surgical treatment, and then outcomes. A bit about Indian data as well. So, okay, why does it not? Okay, now I can move it. Yes. So I'm sure all of us, being a little bit initiated into endocrine surgery and hyperparathyroidism, are quite well aware that parathyroid carcinoma are the rarest of all endocrine malignancies. And if you have to define it, it is a rare epithelial malignancy of the parathyroid glands, which is a very uncommon cause for hyperparathyroidism. Less than 10%, in fact, much lesser than 10% of all parathyroid carcinomas are non functional. not resulting in hyperparathyroidism. And the hallmark of parathyroid carcinoma is severe clinical and biochemical hyperparathyroidism. There are classic clinical, biochemical, gross, and histologic features of parathyroid carcinoma which help us diagnose it. But unfortunately, in a large proportion of patients, they may lack any of these classical features, making it difficult to diagnose them. Surgery is the only worthwhile treatment, and there is really no effective adjuvant treatment. So, radical surgery, first time and whenever required for reoperation, is the only answer. There are possible other ways of treating, like calcimimetics and control. These are all essentially meant to control hypercalcemia in patients with uncontrolled parathyroid carcinoma. But recurrences and metastasis are common. Outcomes depend on adequacy of initial surgical treatment. In spite of well performed surgery, there are patients who are bound to come back with recurrences. So, if you look at the history, the first description of parathyroid carcinoma came as a non functional carcinoma in 1904 by Fritz de Quervain. And in 1933, we find a description of functional parathyroid carcinoma. Uh, so it is the least common endocrine malignancies, and the prevalence is 0.005% of all cancers. Majority of parathyroid carcinoma is sporadic, less than 5% being familial. The overall incidence is quite low, but in recent decades, the incidence seems to be increasing. And there is at least one study which has documented that the incidence increased by about 60% between time periods. In the duration of 1988 to 91, the incidence was 3.58 per 10 million population, and in the time period of 2000 to 2003, it rose to 5.73 per 10 million population as per the US National Cancer Database. As a cause of hyperparathyroidism, the parathyroid carcinoma accounts for less than 3% of all PHPT patients. In fact, in majority of Western series, it is less than 1%. The incidence seems to be somewhat higher in Japanese and Italian series, and we are well aware the relative incidence is much, much higher in Indian and other developing country series. In our own experience, the relative incidence has remained at around 4%. And in most recent review of this, we find it is 3.9% of 429 PHPT patients. Similar figures have been quoted from other series in India. What causes parathyroid carcinoma is perhaps not fully understood. It has been reported in long-standing renal hyperparathyroidism in patients who have received head and neck irradiation. But the only worthwhile molecular basis that we know of, or only foolproof basis, is the cell development cycle 73 gene, or which was called the HRPT2 gene in the earlier years, located on chromosome 1, which is a tumor suppressor gene. It encodes a 531 amino acid nucleoprotein called the parafibromin. And the parafibromin protein is a paraphrase for parathyroid disease and fibroosseous lesions. This gene, when mutated, when we know that germline mutations of this gene are responsible for causation of jaw tumor hyperparathyroidism syndrome. Roughly a third of these patients who have HPT-JT syndrome have parathyroid carcinoma. Though germline mutations are the ones which we initially, or people were initially interested in, but in almost two-thirds of all sporadic parathyroid carcinoma, somatic mutations of CDC73 or HRPT genes are known. We also know that these parathyroid carcinomas at only occasionally or rarely can be seen or have been reported in MEN type 1 as well as MEN type 2A, but these are only anecdotal, very rare instances. So, somatic mutations of CDC73 or HRPT, as I said earlier, have been reported in various series between 60 to 100% of all patients with parathyroid carcinoma. And germline mutations are less common if we consider all the parathyroid carcinoma as such. If we specifically look at HPT-JT syndrome, as I said, it is much commoner. And there are some patients with familial isolated hyperparathyroidism where we know they have a germline mutation. There's a whole kindred, a very large family of FIHPT reported from Italy, which has a CDC73 HRPT2 mutation. Besides the CDC73 mutations, loss of heterozygosity in the long arm of chromosome 13 that has been reported, and this is the locus where the tumor suppressor genes, the retinoblastoma gene or RB1, as well as BRCA2 are located. Similarly, there have been anecdotal reports of loss of heterozygosity in PTEN, HRAS, MET, and TP53. Uh, Coming to the natural history, patients are often diagnosed quite late. Uh, when left untreated, these patients usually have a single parathyroid tumor. The clinical course is not predictable. In most cases, the course is indolent. Uh, Recurrences are known to happen even quite late after surgery for hyperparathyroidism. At initial surgery, especially in earlier years, parathyroid carcinoma used to be missed. The diagnosis used to be missed, and recurrences have been found even after many decades of initial surgery. The tumors are typically found as hard, locally invasive cancers. At times, they may present with, very rarely, they may present with initial metastatic disease, and in which case these are metastases to lungs, the liver, bones. Median survival after first recurrence in some series, at least not so recent ones, has been shown to be quite short. And usually, death is due to effects of uncontrolled and refractory hypercalcemia rather than local invasive tumor itself. So, most often, uh, the diagnosis of parathyroid carcinoma is missed. It is misinterpreted as a benign hyperparathyroidism, but there are certain features which raise the suspicion of parathyroid carcinoma, and these are the ones which I would like to highlight. Usually, patients are young, mostly in the fifth decade, and this is about a decade younger compared to benign hyperparathyroidism patients if we take into consideration the global scenario, global data. In India, as such, we see our hyperparathyroidism patients are younger compared to the West, but even in our own, and in that way, parathyroid carcinoma patients are no different in their age at presentation in our own series. In our experience, the mean age has been 37 years. It is rarely seen in children, and usually the male to female ratio is almost equal. But in our experience, much larger proportion of females have been managed with parathyroid carcinoma. So the clinical presentation of the disease is just like any symptomatic hyperparathyroidism patient that we commonly know or have managed in India. When it, however, in experience of Western surgeons or Western physicians, this seems to be a quite a starkly different clinical presentation because for them, the majority of patients are diagnosed with asymptomatic or minimally symptomatic primary hyperparathyroidism. The common presentations are with bone disease, with bone fractures, renal stones, or both of them together, fatigue, muscular weakness, nausea and vomiting, polydipsia, polyuria, which are symptoms of hypercalcemia, and in few cases, weight loss, anorexia, again mostly due to hypercalcemia itself and not because of metastatic disease. For us, we know that as we have described this entity of extreme hyperparathyroidism, resulting in parathyroid cripple, where patients are crippled because of a combination of advanced skeletal disease, musculoskeletal disease, and vitamin D deficiency. And I'm sure some of you would have seen these descriptions in our publications over last 2 decades. These are again not sign to known for parathyroid carcinoma for us in India. However, if these kind of presentations are seen in rest of the world, in the Western world for sure, they would be seen as indicators of parathyroid carcinoma. So, looking at the global picture, patients usually would present with skeletal manifestations, and they have been described in about 40 to 70% patients, renal manifestations in 30 to 60% of patients, and quite a bit, almost a third of all, are reported to have concomitant skeletal and renal manifestation. In our own experience, 50%, half of all patients with parathyroid carcinoma have concomitant skeletal and renal manifestations. Palpable neck mass is often considered as a very strong indicator of the tumor being malignant when you are able to palpate a parathyroid tumor. But then, this, as we have all known, in Indian patients, it's not so uncommon to find a palpable tumor. And in our published experience, 50% of all parathyroid carcinomas were palpable, but then 27% or one quarter of all adenomas were also palpable. So again, you cannot be certain about the tumor being parathyroid carcinoma if you were looking just from the view of palpability of a parathyroid tumor. There is a certain number of non-functional parathyroid carcinomas reported. We have had just one case in our own experience where the patient did not have neither hypercalcemia nor hyperparathyroidism, and the diagnosis of parathyroid carcinoma was established when we excised a palpable neck mass, which we initially thought was a thyroid nodule. So these non-functioning cases, though few, they present really late, and the outcomes are not as great or even worse as compared to the functional parathyroid carcinoma. And it makes no, I mean, it's not surprising that in a patient with classic PHPT who presents with recurrent laryngeal nerve palsy without any history of prior neck surgery, one must consider this to be malignant, locally invasive, unless proven otherwise. As I said earlier, very few, almost 1% of all parathyroid carcinomas present with metastatic disease, metastasis outside of the neck. Lymph node involvement is not very common, but in various series, it has been reported in up to 30% of cases. When distant metastases are seen, mostly as metachronous metastasis, they affect lungs commonly, but uncommonly bones, liver, kidney, adrenal, pancreas, brain, all kinds of metastatic disease have been reported. And this is one of our own patient managed in 1998, between 1999 and 2002 or so. This lady, soon after, almost 6 months after the initial treatment for parathyroid carcinoma, presented back with seizures, and we found she had multiple brain metastases. In fact, she succumbed very soon after that. So, in terms of how do we establish the diagnosis, you would establish the diagnosis as you would do for any PHPT patient by doing biochemical estimation, serum calcium, phosphorus, and PTH, vitamin D. Uh, these patients often or almost always have very high serum calcium levels, usually more than 14 milligram per deciliter. And PTH levels are also extremely high, definitely more than 2 times upper normal. And these patients, because they have skeletal disease, have high alkaline phosphatase. You can suspect these patients because the skeletal radiology would show classical features of osteitis fibrosa cystica. These patients would have gross osteoporosis on BMD. And once you have established the biochemical diagnosis, you try and localize the parathyroid tumor using a combination of a functional system EB scan and an anatomical high resolution ultrasound. But you can also use contrast enhanced CT, and in patients with recurrent or elusive parathyroid tumor, you can even use 4D CT. FDG PET has been shown to be useful in knowing the extent of disease in patients where you are able to suspect the disease or the malignancy preoperatively, because it would tell you about whether or not an aggressive surgical treatment or aggressive prognostic importance. These kind of skeletal pictures, I am sure all of us are quite well aware. Patients with osteitis fibrosa cystica showing subperiosteal bone resorption, salt and pepper skull, absent lamina dura in the teeth, and diffuse spinal osteopenia. I'm sure we have had number of discussions on these in this fraternity of endocrine surgeons, and so I'm not really going too much into details. One specific aspect of skeletal radiology I would like to remind my younger colleagues, because uh, some of us who have trained and who have worked in the 1990s and perhaps earlier part of 2000, the decade 2000 to 2010, we have seen many such patients. But now, fortunately, such patients with disappearing bones or syndrome of extreme or a syndrome of parathyroid cripple or syndrome of disappearing bone have now disappeared altogether, almost altogether. And you can see this is a set of radiographs published by us in one of the previous publications. The bones are almost invisible, but interestingly, after parathyroidectomy, the brown tumors, they kind of fill in with calcium and minerals and show up on radiographs, and then in follow-up they gradually they lighten up. So these are interesting skeletal radiology, which are very few in very few cases have been reported. Patients may have bilateral, multiple, staghorn, other kind of calculi, and this is an interesting radiograph because besides bilateral renal calculi, you can see another very interesting thing, which is uh, unfortunately this platform is not very interactive, but would have been good to know from any of the students. But this is a chain of lakes sign. I'm sure all students of general surgery know what it is. I'll leave it for the end to discuss another view of the same patient. So you can see the calculi are seen in two planes. This is the plane of kidneys and the ureters, and there's another set of calculi which, time permitting, we can discuss later on. This patient had extreme osteoporosis. A lady who had a suspected parathyroid carcinoma turned out to be atypical adenoma, but this is not uncommon to find patients with extreme osteoporosis. And the same can be seen on various other radiographs. Classical features of subperiosteal resorption, tufting of terminal phalanges, bone cyst on and X-rays, and finding a large parathyroid tumor in majority when we do a system EB scan. The same is true on ultrasound. You would find a large tumor seen on almost like a third thyroid lobe. And if it is invading the tissue planes, then you know that you are dealing with a parathyroid carcinoma. And this is a picture of a patient with parathyroid carcinoma. You can see the edges, the margins are fuzzy, they are invading into the surrounding soft tissue, and this should raise the suspicion of carcinoma. System EB scan is useful in helping in localization of the tumor, but it does not offer any differentiation between benign and malignant parathyroid tumors. In varying degrees of or varying extent, to a variable extent, MIB can be found to be concentrated in not just in the primary tumor, but rarely in the functional metastatic disease. And this is usually helpful in the follow up of patients. But they've been reported of bone cyst and brown tumors, which are not really metastatic lesions, but which are part of osteitis fibrosa cystica, the classical skeletal manifestation of primary hyperparathyroidism. Those two have been known to concentrate system EB. But in context of parathyroid carcinoma specifically, 18F FDG PET and at times carbon 11 methionine PET are useful in both initial localization and in follow-up. There is no role for FNAC. Usually, it would not be advocated, not just because it is not very useful in distinguishing benign and malignant tumors, but also it carries a risk of needle track implantation, as we have reported earlier. FNA of a fine needle aspirate for cytology and PTH estimation can be used in characterizing possible metastasis or in the reoperative setting. In benign hyperparathyroidism, FNAC can lead to alterations in the histopathology, which may mimic carcinoma later on, and that is another reason why we usually do not advocate a parathyroid tumor to be aspirated. We do not put in a needle into a parathyroid carcinoma, whether it is benign or malignant. We reported in way back in 2006 or so, yes, 2006, a patient with parathyroid carcinoma who was initially treated in 1996 had a and then came back with a recurrent skin nodule. This skin nodule was quite perplexing. The patient was totally asymptomatic. The biochemical picture was normal. She didn't have hypercalcemia. But when we evaluated this skin nodule, we found it had uh, parathyroid carcinoma deposits. And then on reviewing this chain of events, we found this recurrence was along the needle track of FNAC from this palpable neck mass initially, and we reported in Langenbeck's archives of surgery. So looking at all this clinical biochemical imaging picture, when do you suspect parathyroid carcinoma in a patient who is presenting with primary hyperparathyroidism? Usually, you would find a symptomatic patient who's young, who has concomitant skeletal and renal disease, and usually the patient may have palpable neck mass. The patient may or may not have, sorry, the patient may or may not have uh, how do I go back? Need to go back. Yes. So patient may or may not have uh, palpable neck mass, may not have any distant metastasis. More often not, the patient would not have metastatic disease, but the patient would have markedly elevated calcium and PTH levels. So this is when, yeah, a very high index of suspicion needs to be entertained, because that is the only way you can detect majority of parathyroid carcinoma before operating. While it is good to say that these are the features which make you suspicious of parathyroid carcinoma, but in our own experience, unfortunately, all these features, young age, palpable neck mass, symptomatic disease, concomitant skeletal and renal manifestations, extremely high serum calcium and PTH levels, and large parathyroid tumors, which of course also reflect in terms of palpable parathyroid tumors. These have been found in quite a significant proportion of patients with benign parathyroid tumors and hyperparathyroidism. And the only difference we have reported comparing patients with benign parathyroid tumors and malignant parathyroid tumors in this publication in 2006, which included 100 consecutive cases of PHPT, was that the tumor weight in patients with carcinoma was significantly higher as compared to patients who had benign disease, parathyroid adenomas. And then otherwise, all the other features that we talked about earlier, including palpable disease and extreme degree of hypercalcemia, hyperparathyroidism, they were comparable. So I think it is more of a function of whether we are dealing with symptomatic is or asymptomatic and minimally symptomatic PHPT patients, that these things may help in differentiating benign versus malignant. But it is always good to have these things in mind if in presence of such features, to consider parathyroid carcinoma, because as I said earlier, that's the only way of detecting parathyroid carcinoma preoperatively. So we are now dealing with a cancer, and it makes Intuitively, this cancer must be staged, but you may find it interesting that the first TNM AJCC staging for parathyroid carcinoma was proposed as recently as just 3 years ago. So, because of the rarity of this disease and because of lack of clear lack of clear prognostic and predictive features, both clinical, imaging, biochemical, the TNM AJCC had so far never um, proposed a TNM staging. It was only as recently as 2016 when it was proposed, and then the eighth edition, which was finally published in 2017, that TNM classification has been brought out. Of course, Dr. Shah and Shah in 1999, in a paper in Cancer, they had proposed a staging system which was used until 2016. But the current TNM AGCC staging is where atypical parathyroid tumors are called TIS. T1 is any size of parathyroid carcinoma which is limited to the parathyroid, or if it is extending beyond, it is limited to soft tissue. T2 is tumor invading thyroid gland. T3 is tumor invading recurrent nerve, esophagus, and trachea. And T4, those invading major blood vessels of the spine. Similarly, if there are no lymph nodes, of course, it is N0. If there are central nodes involved, this is called N1A, and then lateral neck nodes N1B, and presence and absence of metastasis as usual. So, as it would be apparent to you, this staging is almost always possible to arrive at post-operatively and not pre-operatively. So, so far we have talked about the clinical presentation, the diagnosis, imaging, and staging of parathyroid carcinoma. Now, coming to the treatment. So, in this whole big uh, canvas detailing the parathyroid carcinoma, the only thing worthwhile mentioning is surgery, because that's the only proven useful treatment. There's no worthwhile adjuvant treatment with proven efficacy. However, because it is so often required, all kinds of experimental therapies have been tried, and we'll talk about it. When we talk of parathyroid carcinoma surgery, it is the only effective modality. And what you do is try to do an en bloc resection of the parathyroid tumor along with any adjacent involved neck structures. These may be the strap muscles, the recurrent laryngeal nerve, the thyroid, even esophageal wall, and then whatever other structures may be involved, because that's the only effective way of controlling the disease or attempting a cure. You may or may not include central compartment lymph node dissection, usually on the side of the tumor, and if required, lateral neck dissection, only in presence of metastatic nodes. And you must avoid spillage of tumor cells because that will be catastrophic. Lymph node metastases are not very common, and so therefore central compartment node dissection should be done only if there are enlarged or metastatic nodes. There has been no recorded proven benefit of prophylactic central neck dissection or lateral neck dissection, and so it must be reserved only in patients where you have some evidence of lymph nodal metastasis. And here is one example of a large invasive parathyroid carcinoma. This is the tumor, and this is the hemithyroid specimen along with the central compartment, hemicentral compartment dissection, because there was one enlarged node. So we did a hemicentral dissection. There was another node which is not represented here because that was sent for frozen section evaluation. So as and when you are facing a patient with in a tumor invading any of the structures surrounding it, you must do an en bloc resection. There's been some experience or reported data where uh, adequacy of surgery has been very aptly or very adequately addressed. And this paper in 1999, uh, the authors reported that wherever an en bloc excision of a parathyroid carcinoma was done, the local recurrence rate was 8%, whereas in those patients which underwent just simple parathyroidectomy, the local recurrence rate was as high as more than 50%. And similarly, it did reflect in overall survival rates in patients who had undergone the initial en bloc resection. The overall survival rates at 5 years was 89% compared to survival rate of just 53% in patients who had a simple parathyroidectomy and not an en bloc or um, a radical parathyroidectomy. Post-operatively, majority of patients would develop hypocalcemia, and that's again may not be such a rare phenomenon in our Indian patients, but it is something of interest, and it may be a very startling occurrence in an experience of Western surgeons. And symptomatic hypocalcemia needs to be managed, as I'm sure all of you would have managed post parathyroidectomy for benign as well as malignant parathyroid disease. The gross pathology usually is quite a classical one. The classic parathyroid carcinoma is an irregular, usually lobulated or nodular tumor, which is gritty, white, gray, and quite firm on cutting. And this is a specimen of a rare intrathyroidal parathyroid carcinoma. Once again, we have reported this. Uh, this was a patient where the parathyroid was elusive, and though it was localized on system EB scan, we could not locate it right away during surgery, but the ultrasound features the surgeon performed ultrasound features did give us a clue that this may be intrathyroidal parathyroid tumor. And so we did a hemithyroidectomy, and on cusp surface we found a nodular gritty parathyroid tumor, which was then finally reported as parathyroid carcinoma. Histopathology of parathyroid carcinoma itself has been quite an interesting story. The first reported set of histological features were reported by Shantz and Castleman, which were modified later on by Bodinson, and then in 2004 we had the first WHO classification. And the features which are indicative of malignancy on histology are capsular invasion, broad fibrous septae or bands, vascular invasion, frequent mitotic figures, though those are not very classic of malignancy, invasion of surrounding structures, and lymph nodal metastasis. Mere cellular pleomorphism or atypia is definitely not indicative of malignancy. These features on histology, they help us diagnose as well as prognosticate. In one series, very classically, presence of vascular invasion had a very high probability of in predicting poor prognosis and local recurrence. So was invasion of surrounding structures, but presence of fibrous bands was shown to have a protective, it was shown to result in much lower incidence of local recurrence. So these are some of the classical histopathology features: hyperchromatic chief cells, which are either which are laid down in sheets or trabeculae, capsular invasion, as well as presence of wide. This is a picture showing intravascular tumor thrombus or vascular invasion, and presence of such wide fibrous septae. These must raise the suspicion for parathyroid carcinoma. Parafibromin immunostain is again something which we usually do for differentiating adenoma, atypical adenoma, and carcinoma. And you can see in a patient with parathyroid carcinoma, the parathyroid immunostaining is almost completely absent. And this is classic of parathyroid carcinoma. Uh, at times, or rather many a times, the diagnosis of parathyroid carcinoma would come only as as a histological surprise. What do you do in that scenario? If the pathology seems an aggressive one with presence of gross capsular invasion, vascular invasion, and the patient has persistent hypercalcemia, hyperparathyroidism, you can plan to reoperate the patient, complete the radical or en bloc resection, which means ipsilateral hemithyroidectomy with or without central compartment neck dissection, excision of any possibly involved structures. However, if the histological features seem only low grade, not so aggressive, and the calcium and PTH levels are not elevated, one can Keep these patients on a close follow-up, which would include 3 monthly serum calcium, PTH, ultrasonography, and hold on to the en bloc resection or repeat surgery as and when a recurrence manifests. Uh, when you have a recurrent parathyroid carcinoma, usually it is in terms of local recurrence or distant recurrence. Multiple reoperations may be required to control the local recurrence or the distant metastasis, as well as for palliation of the hypercalcemia. In fact, surgical excision of or debulking is perhaps the most useful or one of the most useful ways of palliative relief in patients with medically intractable hypercalcemia. Even R1 resections help, even if you are not able to achieve a complete clearance, yet debulking is helpful in palliating. In patients who come back with recurrence, complete cure may be unlikely. So, patients who have symptomatic or significant hypercalcemia need to be treated for hypercalcemia medically or surgically. Repeated resections may be required, and metastatectomy may be resorted to. Adjuvant therapy can be tried in non resectable disease. So, this is an example of the very same one of the first parathyroid carcinomas in our own experience, who has had 3 reoperations for this disease. And this was the picture of second reoperation in 2007, where en bloc excision of mass with ipsilateral central node dissection was done. But of course, the patient has had 2 further surgeries, including a tracheal resection, which was reported recently by my colleagues in Indian Journal of Surgical Oncology. There are anecdotal reports of variable response to cytotoxic chemotherapy, but it is definitely not the standard of care. Anti-PTH immunotherapy has been tried, so has been octreotide and azidothymidine. These are all experimental therapies. In fact, currently there are 3 clinical trials listed on clinicaltrials.gov, and these include these immunotherapies and lutetium dotanate therapy as well. Radiotherapy is not very useful because these tumors have traditionally been considered radioresistant. In last 1 decade, or perhaps more, about 2 decades, in the last 2 decades, there have been some reports anecdotally which have reported lower local recurrence rates following adjuvant RT, but these are retrospective studies with very few patients. So currently, radiotherapy is not routinely recommended post-operatively, but maybe considered for patients who have locally invasive or aggressive cancers, and also for recurrent metastatic non-resectable disease. Management of hypercalcemia is what needs to be very aggressively done in patients who have symptomatic or significant biochemical hypercalcemia. This may be just as you would do for any patient with hypercalcemic crisis, aggressive hydration with saline, loop diuretics, bisphosphonates, calcium mimetics, etc. Other modalities which have been tried in recurrent and unresectable parathyroid carcinomas include ethanol injection, radiofrequency ablation, and PTH peptide immunotherapy, which has been shown to have a transient benefit, and a clinical trial is continuing. How do you follow these patients? These patients need lifelong follow-up. You have a good tumor marker in form of calcium and PTH, but patients with poorly differentiated or dedifferentiated parathyroid carcinoma, serum CEA can be of some use. Recurrence is quite common in patients in these with parathyroid carcinoma, and the mean time to recurrence has been reported at 3 years. According to the National Cancer Database, the 10-year survival was reported at 49%. This has slightly improved. MD Anderson experience has been that the 10-year survival is 77%. The SEER database 10-year survival reported was 68%. And in a meta-analysis reported in 2010, the 5-year survival was reported between 45 and 85%, and 10-year between 35 and 79%. The cause of death usually is refractory hypercalcemia and its complications, and not the tumor invasion or tumor per se. These are the predictors of poor prognosis: male gender, young age, high serum calcium, non-functional tumor, vascular invasion, lymph nodal metastasis, failure to perform R0 resection at the first time, multiple reoperations or multiple recurrences, whereas presence of fibrous bands seems to be indicative of good prognosis. In our own experience over the last 3 decades, we have managed 17 patients until end of last year, which constituted about 4% of all patients of PHPT we have treated. The mean age in these patients was 45 years. In fact, this mean age is higher as compared to mean age of all PHPT patients we have treated. And that's quite startlingly different than the Western experiences. The pre and intraoperative suspicion for parathyroid carcinoma was entertained in 11 further, at least. It may have been entertained even more, because this is something which is not always recorded in the operating notes, but in at least 11 more patients who did not eventually turn out to be parathyroid carcinoma, intraoperative or preoperative suspicion of carcinoma was entertained. 8 of these turned out to be atypical adenomas, and 3 turned out to be classical adenomas. So this is an example of a patient where we had a false alarm. You can see this is the parathyroid tumor. This was a lower gland, quite a large one, invading the thyroid lobe. This is the thyroid lobe. We were wondering if this too is an extension of the parathyroid carcinoma. There was no plane here which could be developed. So eventually, we did the right thing in doing an en bloc resection of this tumor along with the thyroid lobe. There were no metastatic nodes, so we did not do a central compartment dissection. But this kind of false alarm we have had rather too frequently. But I feel still doing an en bloc resection at that time is not a very high price to pay to achieve cure. The proportion of patients with parathyroid carcinoma in our experience has been coming down, but it seems to have plateaued now. And Sanjay, one of our recent MCH pass outs, he, as part of his research, MCH research project, he published this in recent issues of Virginal Surgery, where you can see in the initial cohort between 1990 to 1999, the proportion of patients with parathyroid carcinoma was 11.6%. In the second cohort, in the decade of 2000 to 2009, it came down to 3.57%. In the third cohort, that is 2010 to 2016, the proportion was 3.2% only. And this definitely shows a reducing trend, and perhaps it has more to do with higher number of patients with PHPT being diagnosed and not necessarily underdiagnosis of parathyroid carcinoma. And this is a table listing the outcomes of some of our parathyroid carcinoma patients based on an analysis done in 2009. There were 9 patients all in all, and we are aware that at least 5 of them have died, and the rest have 4 of them have died. One of them perioperatively at 2 weeks, another died 2 months following surgery, but the rest have died of metastatic disease. So in the end, the take-home message as far as parathyroid carcinoma is concerned for my residents and young colleagues, it is a rare malignancy. It is a rare cause of primary hyperparathyroidism, and a high index of suspicion is needed by the treating doctors, both while evaluating and while surgery for PHPT, to diagnose or detect hyperparathyroidism caused by parathyroid carcinoma. But unfortunately, the diagnosis is often missed or delayed, mostly diagnosed post-operatively. The treatment, only worthwhile treatment, is radical surgery at the first time, which requires early identification, pre or intraoperatively, complete resection without tumor spillage, along with excision of any of the invaded structures, offers the best chance of cure. And there is no proven adjuvant treatment. Local and distant recurrences are common, and usually the patients die because of refractory hypercalcemia and not due to the cancer itself. These patients, after surgery, they need lifelong follow-up, as I have described. So that is what I had to talk about parathyroid carcinoma, and we still have some 10 minutes to take any questions that you may have. So I would suggest that please stay muted, but whosoever has questions may put those questions in the chat box, so that we can uh, take them one by one. because if everybody starts talking simultaneously, we'll probably not be able to make much headway. I see some questions. Uh, okay, okay, I see no questions as yet, only comments. I hope I was audible, Pooja. I see you had problem with listening to me. I hope it was better. Whosoever has to speak may kindly unmute himself, speak whatever he or she has to, and then so that we have as little disturbance as possible. Any questions or comments?
Sir, your experience on PET choline CT.
Okay, so let us restrict the discussion to parathyroid carcinoma only. Uh, in our patients with the 17 patients of parathyroid carcinoma, maybe 6 of which have been managed by me and the rest by my other colleagues, I don't remember any patient where carbon methionine or choline PET has been required for detecting the tumor. These because these patients have quite large tumors to begin with, but we have had a patient with very poor function in follow up who had become a de-differentiated, had hypercalcemia, but the MEB stopped being very. The tumor was not um, was not very MEB avid, so we do not have any experience of managing patients with parathyroid carcinoma with choline PET. But yes, we have had anecdotal patients where we requested our nuclear medicine colleagues in patients where we did not have a localized parathyroid disease, especially in reoperative setting, where we have resorted to carbon methionine PET CT. Uh, Sanjay has a suggestion that we need to re-emphasize about the FNAC, or rather lack of its utility. Well, yes, I think it is definitely something worth re-emphasizing. FNAC has very little role, or rather no role to play in evaluation of a diagnosed PHPT case. So if you have a patient where the biochemical diagnosis of primary hyperparathyroidism is quite certain, and the imaging is otherwise not suspicious of another malignancy, which means, for example, a thyroid nodule with overtly malignant features on ultrasound or otherwise, then perhaps you should not do FNA, because as I told in the presentation, it doesn't help in differentiating a parathyroid carcinoma from adenoma, but it does put the patient at risk of needle track recurrences. The only way FNA is helpful is in patients where you are not certain of the diagnosis, in which case you should not just resort to cytology, but the FNA should also be subjected to PTH estimation. You can aspirate whatever material you are able to, dilute it in a bit of saline, know the dilution, and estimate the PTH concentration in that aliquot, and then compare it with the serum calcium and serum PTH. Any other questions? Okay. So should I ask some questions to some of you now? Dalpati, any comments? Any expert comments from Dalpati, from Pooja? I'm looking at the list.
That's an excellent presentation, sir.
Well,
Hello, able to hear, sir?
yes, I am able to hear you quite
That's an
clearly.
excellent
Yes,
presentation
sir.
as usual. We did have a share of 9 cases of parathyroid carcinoma till now. Actually, we are in the process of compiling it, and we will be soon sending for publication. So, actually, one case we did publish in British Medical Journal of Case Reports, where we had a patient presented with hypercalcemic encephalopathy, sir. This is a 49-year-old gentleman who presented with hypercalcemic encephalopathy, and on evaluation, actually he presented to the neuro department. So he had a tumor in the occipital lobe. Then it turned out to be a metastasis. Then we did a surgery. He was on ventilator after, then for a week or so, then we operated. Then it turned out to be a parathyroid carcinoma. Still the patient, the PTH level was not normalized because he had lung mets as well as brain mets also. So he's still on follow-up only. Actually, we did share this experience in this BMJ also. So it was a great learning experience for because they may present any whatever way as you said, sir.
Yeah, thank you, Dalpati. That's a great experience of 9 cases in a short span of time. Would Pooja or anybody else from KGMU, as well as I can see CMC Vellore connected here, would you like to share your experience of parathyroid carcinoma? And so also if there's anybody from All India Institute who is connected. Pooja, can you hear me? Perhaps not.
Yeah. Hi, Gaurav.
Hi.
Hi, Paul. Yeah, sorry, I came in a
Yes.
little late, but I
No problem.
wanted to just share from our experience. You know, the incidents we have seen definitely dropping. Our first review showed 3%, then it went down to 2 point something. Now it's less than 1%. So definitely the disease profile matters. And it is a rare disease, no doubt about it. It's just that we see the sort of very symptomatic ones coming to our centers. So the proportion is higher than what is reported. Our experience, one we wanted to share is we were a little more aggressive with the radiation. We would give adjuvant radiation whenever there was a doubt, say it was not suspected preoperatively and intraoperatively, there were concerns about planes, or it was a very hard fixed lesion, even if we did a central compartment dissection en bloc. We have a paper published in Annals with some comparison with the retrospective cohort and the other data showing that RT may help. I think that was, every center has its own protocol. But our threshold, may I say, is a little lower for giving RT because, it generally, it tends to recur in the neck and it's very untreatable. There is no effective really treatment for it except surgery. So local, regional, maybe. I think each center will have to take its own call on what is their threshold for RP. That's the only additional thing I wanted to point out.
Yeah, thank you. Yeah, that's a great insight. We need to take into consideration whatever measures we can employ to reduce recurrences and ensure lasting cure. I think Pooja and others from KGMU are not joined on this group, and they're perhaps they're following us on the YouTube channel. I would request any other. There's a question from Malika. Can we say that atypical adenoma is a precursor lesion to carcinoma? Well, there is no definite evidence to that. It seems that, the only definitive differentiation that we right now have between atypical adenoma and carcinoma is the parafibromin immunostaining. Of course, there are some overlapping histological features between atypical adenoma and carcinoma, but from that viewpoint, there seems to be no definite indication that atypical adenoma, if left untreated, would become carcinoma. Anybody else, Paul or any of my faculty colleagues, would you like to comment on that? Okay, so any other questions? Another question from Sunil. Incidental parathyroid carcinoma found during surgery. When to do metastatic workup? So the answer is, to some extent, I addressed this. A histological surprise or an intraoperative surprise, you find a parathyroid carcinoma, you manage subsequently based on number one, the gross and the microscopic pathology. If the, as I had shown you, there are features of aggressiveness and features of not so aggressive behavior. Aggressive features are vascular and gross capsular invasion, frequent mitotic figures, and all those, and broad fibrous septae and bands. That is a feature of not so aggressive behavior. Those kind of things. Presence of concomitant invasion of various structures, number of structures invaded, those things. Plus, consider postoperatively if the patient remains to have hypercalcemia, hyperparathyroidism. Those are the reasons when you would do aggressive evaluation, including evaluation for metastatic disease. If you have been able to achieve normocalcemia, PTH has been normalized, there is you've been able to achieve R0 resection, you may not need to do any metastatic evaluation at that time, and do it only when you detect any recurrent disease. Okay, another question is from a Zoom user, which who doesn't name himself or herself. In the presence of multiple systemic metastasis, can we proceed with surgery, or cinecalcet would be an option? Okay, and this is one of those cancers where, uh, especially in patients who have unresectable disease, if the patient cannot be safely operated, either because of very high surgical risk, anesthetic risk, or because the disease is totally unresectable, then you would try systemic options, which are questionable. But as much as possible, even if you're not able to achieve R0 resection, even debulking helps, because that is most palliative as far as hypercalcemia is concerned. So it would be useful to use debulking or palliative surgery. So I think we should end here. We started at 8.
Excuse me, sir. I have two questions, if I may.
Yes,
Hello.
okay. Please go ahead.
So, do you have any standard marker panel that you do for the parathyroid carcinomas on histology, sir? Do you follow a set of markers like parafibromin, RB, BCL2, etc., or is it limited to?
That's right. That is what you do. But because these are such a uncommon, or rather rare cancers, managed no more than once every year. So these are required only very rarely. But yes, we do use such panels. Any other questions? Because I can see Dr. Mishra getting impatient. We have another meeting to start right now. Uh, any other questions or comments? Dr. Mishra, Gyan, any of my other colleagues? If not,
Sir, it was a great presentation, sir. I think my residents should have definitely learned something from it, and you have revised it for them, like last slide. I think that is most useful for them. And regarding that, this is a type of neck mass where FNA is indicated. So it was a great, useful class for them, sir.
thank you so much, and thank you also for joining this webinar. And then I'm thankful to Dr. Paul, Dr. Pooja, and Dr. Anand, and Dr. Pooja from KGMU. Dr. Anurag Srivastava may not have joined himself, but his residents, I can see a few. Dr. Dalpati, Dr. and others from the Madras Medical College. So we have this opportunity to share our academic interactions, our academic deliberations in this time of pandemic. Thank you all very much for joining. So we can leave the meeting now. Thanks a lot.
Thank you, sir.
Thank you. Thank you.
So may I request all others other than SGPGI residents and faculty to leave the meeting, please. The current SGPGI residents and faculty to remain on the meeting. Rest can please disconnect. Thank you. Sanjay, if you can hear me, I'll need to request you to please leave the meeting. Who else? Upender. Upender. Who's Upender? Upender Kumar. CMC Vellore. Endosurgery CMC Vellore. Can you please leave the meeting? Dr. Mishra, can you hear me, sir? So, would you like to start the deliberations? You are muted, sir. You need to unmute yourself. Dr. Mishra, you are muted.
Actually, my tablet did not work, so I'm just connecting from my phone.
Okay.
So just 1 second. Just give me a second.
Sure. Endosurgery CMC Vellore, if you can hear me, please disconnect. And is anybody aware of who's Upender? Upender Kumar. There are two connections by that name. If he is listening to this, please disconnect.
Okay, so let's start.
There are a couple of people whom I'm not
It's
aware.
fine, no problem. Let them join. This is it's not a confidential. It's all okay.
Yeah.
So basically, we are here to prepare for our Foundation Day function that we are trying to see that how much you have gone ahead. So I have listed some of these points that I have sent it already. So if you see all the residents, actually, mostly it is for the resident, and the faculty is just have to cover them up when they need help. The first thing is there is a people who are not aware about how we conduct Foundation Day. So usually there are three main things. One is to presentation of department report. Then we have a Foundation Day lecture, and after Silver Jubilee, we introduce Silver Jubilee lecture. And this time we are getting somebody who is outside the medical field to talk about the stress management during these hard times. And of course, there will be chief guest, the director. Gaurav, I just want to point it out because at this point of time, I am being told that it's difficult to get some higher government officials because uncertainty, and that is a great problem. And it will add the botheration for our kind of busy schedule. So Professor Dhiman, director, will be the chief guest, and I have requested Farin, that is our tradition, the person to be master of ceremony. And I'll request two faculty members also to introduce to this dignitary that is coming as invited guest. Professor Du has already confirmed and he has already given his topic yesterday night. So I'll compile all the program, and by I think as soon as I'm getting free, I'll dispatch it to not only from here, also to outside groups. So that is the part of the entire program. So I am not taking up the Saturday and Sunday, that's 1.5 day scientific program that I'll go up with the program. Basically, we're asking for the residents, whatever cases they have in archive, to come and present theme-wise, just to ask their supervisors or in-charge consultant to talk about it. I've spoken to heads of department of outside GPJ also to chip in, and if they wish, they can present some cases. So the department reports request the first attention now, and here do not have to do much. The chief resident may kindly note that in January, February, already in our teaching program, we have already updated the data. So you have to just add till August 30th. So you have to just get these registers and add those clinical service data, outpatient, inpatient, etc., and just complete that bars and comparative for last 5 years. And here I want a specific mention of the COVID, because in COVID time, all our data has been completely distorted, but you have to find out, in spite of all these problems, what you have done in terms of services. So even the chemotherapy, etc., whatever activity you are preparing monthly, just compile it. It should not be a problem, but I request you to give the responsibilities, and maybe you can distribute Chantal, your domain, whatever the way you like to manage. Next is the list of publications from September, because the activity report includes services and academic activities. In the academic activities, I want to specifically mention about the teaching activities, the normal teaching activity that has happened pre-COVID and during COVID, how teaching activities occurred, and detailed account of the online classes, lectures, and all these things you have to mention. And also, if you have some snapshots of these videos that you have taken recording, you can put some snapshots so that you can show that that's what you're doing as a proof. And the list of publications that has happened by the consultants and the residents, so that may kindly be compiled. That I put a separate request to consultants to provide their corresponding author and past authorship in case the residents are missing out anything. So I suggest the residents can bring out by going to the PubMed and then circulate to all the faculty members anything missing, so they can add to that. Some publications maybe not included in PubMed, so they can also share those things. Then the list of awards that you have issued both faculty and residents. So kindly mention. Please don't forget the resident awards are very important for us to mention. So talk about that also. And also I want the fellowship also you have given to international fellowships, and any national fellowship we have given. I don't remember if I have given national fellowship this year. I don't know when this Dr. Sarangi etc. came. I think they came last year, I think. So here we have only Sunday. So please mention about that. And of course, Sunday we'll have a 5 minutes time that I have included in the program to give her views of her training in our institute. So that is one thing that also we have to include in our department report. So everything that you have done in terms of services, teaching, training, and research, any public health activities, any innovative activities you've done, and besides our faculty members involved in many other activities in the administration of the departments, as well as in international scenario, how their role and etc. also have to mention. So that is one thing that I want, very, very important for us. This is the first thing that I want to tell today morning to all of you. And the chief resident is the main person. Please coordinate. I do not know how many residents are available in your pool now who can actively contribute. I understand that. But in spite of that, still if you want, you can do it actually. And this data I don't require so soon, but at least you have to compile this data. You have to get it from everybody. That will take time for you. So I put a deadline of Tuesday evening so that you're able to compile the data from everybody. This you can give me on sometime in the weekend. Monday evening is the presentation. You can give me on Saturday or so that so you have a couple of days left to organize that actually. Regarding cases for our scientific programs, so it is the same way that we're going to do the way Dr. Gaurav just did now. So we'll have a Zoom connections or whatever video conferencing tools we're getting it, and also we'll also connect to YouTube. So we'll have participation from overseas, especially from Africa and some other Asian countries, neighboring countries. So we should prepare for that, and we'll seek their registration a day or 2 days before. So we'll have a correct figure how much we are going to have presentation there, participation. So any comments from your side? I just want to listen from you. It's a very brief meeting. I'll finish up very quickly. Dr. Malika, if you are there, can you let me know how to organize this thing?
Yes, sir. Sir, I will see the pool of residents that are present currently and then divide accordingly, sir. And then I will bring all the data to you, sir.
Now, what I said, the plan actually, I know the busy schedule for all of you, including faculty also. So I'm very sensitive about that. So that's why I said, what are the things that you can quickly do it, because the statistics already we have, you know, only thing this year statistics you have to add to that. We have up to December, right? So from December till August 30th. So if you just give 1% this job, or you want to give 2% to the job, the way you have done it for alerting this presentation at the end of the year, so we can do it very quickly, right? But I don't want people to spend more time in this. So maybe you can give it to somebody else and you work on compiling these things. Like I've circulated a mail to everybody, all faculty resident. You can also reinforce that by circulating it and to get their information, personal information, because even knowing that they have attended they've given some lectures somewhere. But nowadays, many things are not known, who is doing what, because everything happened online, right? And
Yes.
so it is difficult to find out. Otherwise, you get from the record in the office to find out who are invited to give lectures. So this you have to bring it from them. So request you reinforce that and get it from them. Then we compile. So that is another thing which will take little time, I suppose. And the residents sometimes forget, you have got some assignment overseas. Even last time when they presented their reports, that also I found logbook report, they missed all those things. So please don't ignore these things. If you may not feel it important for you, but it's important for the department. Try to understand that, right? Even if you have spent for 3 days in a fellowship program somewhere, please mention that. If you have visited some center abroad, please do mention that actually. So that is very, very important for us. And residents have got some awards also. So please do mention about that. So these are very important for department to project actually. And regarding the cases, I just want to say, I'll send you circular, but before that, I'm requesting to all of you, whatever cases you have complete information, you are presenting endoradiology, endopathology, all this thing information, you can just little bit add to that and make this case presentation. What we'll do is we'll prepare cases from our side. We are giving sufficient time to for presentation cases. We don't want to pack these things. 15 minutes we'll give, or so 10 minutes we'll give for presentation, and the end of the presentations, every session will be 1.5 hours. 30 minutes we'll keep for panel to discuss. So every session, for example, is a parathyroid benign. Then that will be dedicated session, and 1 hour we'll give 6 presentations of cases. At the end, there are 30 minutes for panel discussion. So that's the way actually you can have elaborate discussions. We don't have to question answer at the end of each presentation. That takes a lot of time actually. So we'll put the panel of the faculty in the below, and there will be a coordinator who will just coordinate these cases one after the other. But we'll make the chairman of the panel to be coordinator, and the rest of the panel will be there at 9 o'clock. So for example, after 1 hour to take part in deliberation, then we go to the next move. So in that way, we can really adjust many cases from other centers also. And no special preparation, not to go to pathology to ask for histological diagram, not to go to radiology to ask for radiology. They'll be there in the panel. I've discussed with all of them. All these things where we know ourselves, we just read out the report and there will be discussion on that actually. So like today, you had a discussion on Dr. Gaurav's presentation. So you can have similar kind of discussion. So we make it as simple as possible, as friendly to all the participants. So any comments from anyone? If faculty is connected also can please give your opinion on this. The resident also, please feel free to interact. We'll have one more day, I think 2 days before 7th. So we'll get some more time. By the time we've prepared something, you can post that, but don't wait for the day to come, but you can circulate.
Okay, sir.
So any resident present want to share anything else in that? So Malika, take the lead as chief resident. Please distribute the responsibility and keep me copied. Okay.
Okay, sir.
Yeah. So that's all I wanted to say.
Thank you,
I don't want to take much time over that. Let's go on work. Okay. Thank you very much. Bye.